It is a wonderful occasion to welcome Eric Rosenthal. He's an independent journalist, and Dr. Donald L. Trump, MD, an oncologist, to the podcast. Um, in order not to confuse the good doctor with the upcoming president of the United States, he shall be referred to as Skip. That is his nickname. And of course, the inevitable Dr. Donald Trump has no personal or ideological connections to the upcoming president. Anyways, they wrote the wonderful book, Centers of the Cancer Universe, a half century of progress against cancer. Skip, Eric, welcome to the show. How are you?
Thank you. Thank
Thank
you
you. Pleasure to be
for
here.
having me.
Okay, so let's begin by discussing how has American oncology as a field developed compared to 50 years ago.
Skip, you want to start?
No, I guess one way to look at this is to remember that 50 to 60 years ago, oncology wasn't a discipline. In fact, the development of the, the 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 infrastructure for treating cancer patients and the science for understanding how to treat cancer patients developed slowly. And in the 1950s, 1960s, there were many who felt that the time wasn't right for investing resources into treating cancer patients. Cancer was viewed as a disease that couldn't be treated. Uh, Patients were sometimes not admitted to the hospital because they had cancer. It's not a unique story in history, but certainly it's important to, as we look back, to remember that 50, 60 years ago, the uh, approach to cancer and not to mention the successes in approaching cancer were very, very different than they are today. And those biases against the treatment of cancer in many institutions slowed the development of organized programs for the treatment of cancer.
Yeah, it was interesting because most of the founders of oncology, they were not oncologists because it wasn't a discipline then. Some were pathologists, they were surgeons, they were let's see what uh, internists and others. But Skip has an interesting story too because he's an alum of Johns Hopkins, and you were there when the National Cancer Act was being signed. And can you talk a little about the history of Hopkins' reluctance to embrace cancer as an academic and as a research discipline, Skip?
Yeah, it's certainly hard to prove the story I'm about to tell based on written documents, but having talked to many people and having been there in a very junior position myself, I think there's a lot of truth in it. And that is that Hopkins shared the reluctance to invest in the treatment of cancer that was present in many institutions. And this reluctance included the assignment of space for the developing cancer program to at that time, the city hospital, which was 5 to 6 miles across the city of Baltimore from the main Hopkins campus. And I think for many years, the many of the powers that be or that were in medical leadership at Hopkins were unconvinced that investing substantial resources in the treatment and research in cancer was justified. Now, of course, that all began to change when the National Cancer Act was passed and resources became available to build buildings and support the development of programs. But I think it's true that in many of the very well-known institutions around the country, the uptake and enthusiasm for developing cancer programs was quite slow back in the 40s, 50s, and 60s.
But even Skip, as we pointed out, even those during the legislative hearings for the National Cancer Act, there were certain established medical research and institutions and societies that were opposed to the National Cancer Act.
Right. Yeah, it's interesting to look at the list of those who testified in favor of and against the passage of the National Cancer Act in the Senate and the House of Representatives, and some very well-known institutions that you would have thought would have been in favor of investing in cancer weren't convinced that the time was right, and so argued against the what they viewed as the disproportionate emphasis and allocation of resources to a single discipline that was very much in its infancy and development.
It's not something they brag about these days.
Before we talk about the National Cancer Act, which was signed into law in 1971 by President Richard Nixon, um, tell us about the current challenges facing cancer research and treatment.
Well, the broadly speaking, I think the current challenges are similar to the challenges that existed in the past. That is, uh, there's always been the challenge to understand the science underlying the development of cancer, because I think if you look at the history of cancer treatment, the major advances have occurred primarily following the delineation of the science underlying those advances. Perhaps the best example of that in recent memory is the development of agents such as the checkpoint inhibitors that stimulate the immune system. They've been markedly beneficial in influencing the course of cancer treatment in the last 10 or 15 years. But it's important to realize that for all of my career, there were attempts to stimulate the immune system to reject a cancer. And those attempts were largely unsuccessful. Very little in the way of successful immunotherapy was possible until the understanding of the immune system, the checks and balances that control the immune system were understood. So it's and that this speaks, I think, to the question of what's the role of investing in basic research in cancer or any medical discipline. And I think it's absolutely true that without understanding the basic science of a disease, you can't really develop effective therapy. So that challenge to understand better and better the basic science, the continuing need for there to be investment in cancer is another major theme. And I think as cancer programs have developed, unfortunately, it's true that disparities in access to effective treatments have become more and more evident. And there are social, economic, in some cases, racial barriers that are still to be overcome to provide equitable access for all citizens to the latest advances in cancer research. And that's in the United States. If you look at the disparities in access to cancer screening and cancer treatment across the world, those disparities are even more striking.
It's interesting because I mean, there are a number of reasons we wanted to do this book, but one of the reasons was it was approaching the 50th anniversary of the National Cancer Act, and we thought it was important to put into historical perspective how far we've come in cancer research and treatment. And we found that that perspective was not that well known even among oncologists today. Um, people make comments based on anecdotes, nothing's being done, my aunt died of this or that. But we try to make the point about how far we have come. And what is it now? 16 million cancer survivors, Skip,
At
something like
least,
that.
yeah.
And more people are living with cancer than dying from cancer. The other thing was what the challenges that we've always had, in addition to the scientific and medical ones, have been just accessibility and affordability. of care. And that was another thing we looked at in terms of the expansion of National Cancer Institute designated centers to have better care um, uh, available to more people throughout the United States. On the political side, since that's something you're interested in, I'll speak for myself right now. I'm a little concerned about what the history of what the future of any type of research and science is going to be with the incoming administration, where uh, at least people from the medical and health side are not exactly pro-science. So that's a little concern, and I think the NIH and maybe dealing with some new challenges in terms of funding.
Okay. I think we can discuss, what to expect in the coming administration. But as I've mentioned before,
But
well, I'm not a medical student, and I'm not a an MD, unlike Dr. Trump. But I am very much interested in the political, social, and
mhm.
legislative aspects of cancer research and treatment in the United States. And that
We-
brings us to the passage of the National Cancer Act in 1971. So why don't you give us a brief legislative history of how that bill came to be a law?
Skip, do you want to start?
Yeah, well, among the places that we focused in writing the book was to outline the advocacy and the advocates that developed the enthusiasm for investing in cancer. And I think it is fair to say that among the most important uh, advocates for cancer research and cancer treatment was Mary Lasker. Mary Lasker and her husband made substantial contributions in many areas of medical science. Important contributions. Mary was on the external advisory board for the National Institutes of Health for the Heart Institute before she became a strong advocate for cancer research. Both Mary and her husband were strong advocates for universal health care, legislation to address other unaddressed medical problems such as mental illness. So the Laskers, Mary with her enthusiasm, and Albert Lasker, who had been a very successful businessman and hence had many resources to invest, were, I think, instrumental in the development of the plan to have investment in cancer take off. Among the first substantive things that they did was to substantially reorganize the American Cancer Society. It was with Mary Lasker's support and urging that the name of the institution was changed to the American Cancer Society, and the commitment made by the American Cancer Society to allocate a portion of their yearly fundraising receipts to investment back in funding cancer research. Mary also was very important in organizing a cadre of physicians and scientists, what they called the Citizens Committee for the advocacy for cancer research. And it was from that group of leaders across the country were drawn those who testified in both the Senate and the House hearings for the passage of the National Cancer Act. And if there is a single person to point to for dramatic input and support for what is now a quite remarkable cancer program, I think it would have to be Mary Lasker.
I just want to make clear also that um, the Lasker Foundation was was founded by Mary and Albert. Had died many years before the National Cancer Act, so the proceeds from his investment was carried on, but the work was done by Mary Lasker. We also, one of the interesting things we did, we were writing this book 50 years after the National Cancer Act, and we were trying to speak to as many people who'd been around at the time of the passage itself. But those would be people who were not, I mean, Skip was I think, a resident at that time, or were you his
Resident, yeah.
fellow? Or,
Resident.
but we were looking for people who were fairly senior and had some dealings with the National Cancer Act passage itself. That was a challenge because that would have placed most people in their late 80s or 90s and beyond. But we were fortunate enough to know enough people in the cancer community who had firsthand knowledge. One of the people was one of the people we spoke to was Vincent DeVita. Vincent DeVita had been former NCI director, and then went on to, I believe he was at Memorial Sloan Kettering, and then he was at Yale. He was head of the cancer center there. I think he's still there as a faculty member. Um, but we have an interesting story that he told us about but Skip had alluded to different people who were advocates and working for advocates. And there was one particular gentleman um, who was a patient at NCI. And do you want to tell that story, Skip? And
Yeah, this was a gentleman who had been hired by Mary Lasker to be uh, who was experienced in government. We would today call him a lobbyist, I think, but he was a strong advocate. And it also turned out that he had been diagnosed with a lymphoma, a malignancy of the lymph nodes, the lymphocytes in the body. And he was under the care of Dr. DeVita at the National Cancer Institute while he was working with Mary Lasker. And Dr. DeVita told us that it was Colonel Quinn. Colonel Quinn was this gentleman's name. It was Colonel Quinn who told Dr. DeVita what was going on with regard to the passage of the National Cancer Act, because Dr. DeVita was consumed by his day job trying to develop new cancer treatments and oversee the cancer research at the National Cancer Institute and contribute to it. It was in his early part of his career development. And it illustrates the fact that many of the people actually doing cancer research and caring for cancer patients as the Cancer Act was being developed were not necessarily fully informed about the pros, cons, and the potentialities of the Cancer Act that was signed in December of 71.
what was interesting is a question we asked everybody we interviewed, at least everybody who was of a certain age. Do you remember when the National Cancer Act was signed? Now, in those days, there was no internet, there was no 24-hour news cycle. Um, and so basically, uh, Vince DeVita had told us that he found out, even though he was at NCI at the time, he found out through Colonel Quinn. By the way, Colonel Quinn liked to be called Colonel. That's why we're referring to him as Colonel Quinn. Um, but most of the people we spoke to were completely unaware of what was happening at that time. Um, I put together a conference many years ago at Cold Spring Harbor Laboratory, and we had Vince DeVito was there, as well as the Washington Post reporter who wrote the original story, as well as the editor of the Washington Post science section at that time. And it was just very interesting in terms of discussing what it was like at that moment. But unless you picked up the Washington Post that day, you might not have known about it.
Well, so again, like I said, I'm not credentialed in any ways in the science of cancer research, but from my limited knowledge, I know that most, if not all, cancers are not contagious. Um, so I guess we're fortunate in that regard.
Yes.
But nevertheless, to what extent is cancer of all types is a public health problem?
Well, it's for decades and decades been recognized as a public health problem uh, because for many years it has been the first or second or third leading cause of death, depending on how you aggregate populations. As a source of pain, suffering, and mortality, cancer ranks right up there with heart disease or any of the, and well ahead in terms of frequency of many other illnesses in this country. There's no doubt that it is a public health problem. As I said, ranking number one or number two, depending on what subgroup of individuals you're looking at. But it's also true that since the passage of the National Cancer Act, the mortality rate from a wide array of cancers has decreased substantially, pretty much across the board. That's due in large part to a better understanding of what causes cancer and the development of systems to detect cancer at an earlier stage so that it won't be a cause of mortality. Recognizing the causes of cancer, the poster child of that concept is the link between tobacco use and cancer. The substantial decrease in tobacco use over the last 40 years in this country is probably the most important thing to account for the decrease in the cancer, in the mortality and cost of the care of patients with lung cancer and cancer of the upper airways and the mouth and pharynx. So recognizing the causes of cancer has been very important, and we're still trying to understand the causes. It's in relatively recent times that we recognize that there are viruses that are transmitted that do contribute to the development of cancer. Viruses, the papillomavirus that is associated with cancer of the mouth and head and neck, also associated with the development of cervical cancer, the hepatitis viruses that are associated with liver cancer. So while the vast majority of cancers are not infectious or transmitted by infectious agents, there are certainly an important number of cancers that are exacerbated, or the likelihood of getting a cancer in that organ, like the liver or the cervix or the head and neck, is markedly increased if you acquire one of these viruses.
Also, one of the important things about, because our book deals largely with the creation of the National Cancer Institute designated cancer centers. And there are three requirements to become a comprehensive center, which is the highest tier. And that is basic research, clinical research and treatment, and population science, prevention and control. And that's where a lot of the public health aspects come into it. There's a lot that could be done. Skip spoke, about tobacco as one issue, but there's a lot can be done to prevent different cancers beforehand. It's not normally covered that much by the media because it's less prevention's less sexy than dealing with the disease itself. The story is less interesting to find that somebody didn't do something and didn't get cancer than how somebody deals with it and struggles with it and gets treated or potentially cured of it. Um, but that's become one of the most important aspects of the cancer. Also, as Skip had mentioned, the basic research, understanding what causes cancers, what are the mechanisms. Um, that's something that's always been key to the research. Um, and so, from a public health point of view, well, one other aspect of this is cancer centers, NCI centers, have to reach out to their respective communities and serve their needs. And many of these are underserved communities throughout the country, different underserved communities, depending on where in the U.S. they are.
Yeah. Well, I'm glad that Skip mentioned the tobacco lung cancer connection. I immediately think of that movie, The Insider, with Al Pacino, as an illustrative example, but also of my own home country too, where rates of smoking amongst all ages is just abysmal. Um, uh, uh, Given my understanding of the history, there are two, I guess, issues that the um, advocates for cancer prevention and cancer research were fighting for, right? So there's the connection itself between um, tobacco use and lung cancer, which there was a huge scientific battle to prove that connection. And of course, there were so-called scientists being funded by big tobacco companies, I suppose like Philip Morris, in order to, publish research contrary to that claim. But there's also the legislative side. So right now, uh, I know that in my home country, tobacco cartons and boxes are marked with like really graphic images of damaged lungs and the letters that says smoking kills and all that. I'm sure that is the same in America, in addition to the taxes. But of course, those of a more libertarian conviction would say that, well, that amounts to a kind of quasi-prohibition, right? I mean, because prohibition was brought about because there was a market correlation between alcohol consumption and uh, deaths, motor traffic deaths, caused by drunk driving. So I suppose we can focus first on the scientific battle to prove the correlation between tobacco use and lung cancer, and that you both can illuminate me on the history of it.
Well, speaking for myself, I don't consider myself an expert on the ins and outs of that battle. You are correct that it was a long process between the first public statements on the part of officials that there might be a link between tobacco use and cancer to achieving labels and restrictions and taxation approaches that have been important to control the use of tobacco. The issue is not one of purely historical interest as we continue in this country to struggle with the right balance with regard to not only tobacco products, but what's many consider the sort of gateway products that might lead to tobacco use, and that's the various vaping approaches. So there's no doubt it was a difficult struggle and took many years to get to the point that we are now. And I think it's fair to say that there is no better example of the merit of that approach than to look at the remarkable decrease in the number of deaths from lung cancer. And there's no reasonable explanation for the decline in lung cancer mortality except the diminished use of tobacco products. So I think it's often difficult to prove those things, those kinds of linkages in large populations. But I think in the case of tobacco, the proof is quite solid, and tobacco avoidance saves lives.
I think um, it's also ironic that with the tobacco settlement that took place, do you remember what year that was, Skip? The settlement money, but it was
No, early to mid 80s. I'm not sure, Eric. That's good.
but it
Good
was
think.
billions of dollars went to various states, and some of the cancer centers that were created relied heavily on that money, and also certain cancer centers that had already been created use that settlement money for research. It's also interesting that Albert Lasker, when he was an advertising official, had been advertising cigarettes, but basically so much of the money from that foundation went to anti-smoking and tobacco efforts as well. So it's interesting that you have uh, research being sustained today through tobacco money, or some of it, at least some
The
of it.
settlement that Eric refers to was signed final settlement was signed in 1998, an agreement between more than 50 state and U.S. territorial attorneys with the four biggest tobacco companies that basically brought billions of dollars into the states for investment in ideally in cancer control, cancer prevention, particularly focused on tobacco-related cancers.
And you also had, I remember I was at Fox Chase Cancer Center in those days. that Fox Chase and the University of Pittsburgh and the University of Pennsylvania, three of the NCI designated comprehensive cancer centers in Pennsylvania at that time, would work together jointly to use the money. Not They would basically meet with the legislators to figure out what to do with the money. So there was more collaborative efforts towards spending it.
Well, on to the second aspect of it, the legislative part. I'm sure both of you can remember a time when you can smoke whilst on an airplane. I can't because I'm way too young for that. And I think it's a better deal for, that way. But I do remember, indoor buildings, indoor semi-public buildings have multiple no smoking signs of it. And even bars these days, if you want to smoke, you have to go outside, and to suffer the cold if you're in cold weather. So again, bringing back the quasi-prohibition objection from, I guess, those of a more libertarian um, conviction, is this current status quo legislative scheme to prevent indoor smoking, to prevent lung cancer effective?
Well, I think it's effective if you accept the argument that the decline in tobacco-related mortality. I mean, we should also recognize that tobacco is not only a cause of cancer, but it's also a major contributor to coronary artery disease and vascular disease. So, and those diseases have also diminished in their burden over the last 40 to 50 years. So if one relies on the science, ranging from the basic science at the molecular level, where you can show the negative effects of the contents of tobacco smoke, all the way to the epidemiologic data that show that populations who are exposed to less tobacco have less coronary artery disease, vascular disease, and cancer. From my perspective, there's no question that restriction of access to tobacco on the part, restriction of particularly young people to the access to tobacco at a time where you can then reduce the likelihood that they will develop an addiction has been very important in the control of mortality and cost to society of the development of both heart disease and cancer.
And just on a very personal anecdotal note, I just returned from a week in touring Italy, and just walking down the streets, uh, I had more asthma attacks than I've had in the U.S. in quite a while because of the tobacco smoke, and this was outdoors, which you don't get too much in the U.S. these days. Um, so most smoking is banned in almost all buildings that I'm aware of. Um, the community where I live of 1,400, it's mostly a retirement community. Smoking is absolutely banned throughout the campus, inside and outside. And I think it's less of an issue, but I know that in when I've been to Europe or to Asia, smoking is much more prevalent than you would find back here. Um,
It's also important to remember that the components of tobacco smoke there are carcinogens, chemicals that damage DNA, lead to mutations that cause cancer. And it's not just lung cancer that can be caused by exposure to tobacco. Almost every cancer, when examined carefully, you will find a component of tobacco use that is felt to be part of the causation of such cancers. Cancers of the urinary tract, like bladder cancer, leukemias have been associated with tobacco use. So it's not just lung cancer, although lung cancer would be quite enough, thank you, if that was the only cancer caused by tobacco use.
Well, Eric, you've alluded to your concerns regarding the upcoming presidential administration in your country and the risk it may face to um, the process of cancer research, not to mention the similarity of the names of the new president with our good doctor. So tell me, how can the American health system in general be more congenial to cancer research, given the new administration?
I can't answer specifically. I do know that the people who've been recommended for top positions in medical and health positions generally are not qualified as others have been in the past, and some of them have biased views on vaccinations or on different types of research, and that's a concern. I think the only personally, I think the only uh, chance we have right now is for Congress, specifically the Senate, to stand up to some of these appointments and keep democracy in check in this country. But it's also during the election, the campaign itself, a lot of the talk was more anti-scientific. There's been more of a trend through society of dismissing science. And that's something that is incredibly important for us all not to do. Um, and I mean, there's talk currently of I think a preventive um, um, pardoning of certain individuals, including Anthony Fauci, who didn't do, as far as I'm concerned, never did anything wrong to be pardoned in the first place, because during the COVID epidemic, there were forces that were not as scientifically stringent as his were. Um, and so I think it's really important for us to follow the course of science in treating disease and methodology. Um, but there've always been issues related to certain aspects of health. For instance, years ago, judges were making legislative issues on whether bone marrow transplantation should be used for solid tumors such as breast and ovarian. And when the clinical trials came out, it turned out that those assumptions were incorrect when they were proven through clinical trials. So I think the public still needs to be more aware of the importance of science and following science for the sake of science, and not just taking anecdotal information and things that have not been proven scientifically.
Yeah, the thing that concerns me most is, as Eric has mentioned, the general uh, tenor in some circles of mistrust of science and the scientific method. And I think the continued provision of high quality cancer care and the development of improved cancer care will be dependent on the continued development of new scientific programs, new research findings. There's no doubt that there are a large number of people heavily invested in scientific research, both at the National Institutes of Health and programs supported by the grants provided by the National Institutes of Health. And it would be easy to argue that there's money wasted and there are more people than ideal in supporting those functions. But I think one has to be very, very cautious in assumptions about such matters because it should always be based on the scientific method and trusting in science. And science isn't always linear. Scientists make mistakes. The reason the scientific method involves developing a hypothesis, a suggested reason why something happens, and then testing it. And oftentimes the hypothesis is not able to be supported. That doesn't mean it was wrong or it was a mistake to have done that research. It's just the fact that for knotty problems, it is difficult and often, as I said, nonlinear in the ability to develop a hypothesis, experiment, and then a proof of principle based on a series of experiments. So I think the scientific method and those committed to scientific explanations for phenomena that are problematic in our country need to continue to have a very strong voice, and we should be very careful about concepts regarding restricting that kind of work.
And part of the problem in the past has been we have to learn from those mistakes, and a lot of, shall I say, failed hypotheses have not been published, have been suppressed by the companies or whomever. Um, if we knew the outcomes of all of these research trials, we would learn more from, I mean, we'd learn more from the mistakes as well as from the advances. The other thing that I'm a little concerned about, which is a little um, well, is the growth, at least in the U.S. This doesn't affect cancer centers per se, but medical health in general, with the growth of private equity investing in medical practices. I'm seeing that as just as a medical consumer now, more and more of medical care is being figured out on cost rather than medical need. Um, and so that's been an effect also in terms of, for instance, in the Philadelphia area and beyond, where I'm located, almost all of the gastroenterology practices have been bought by a single entity. And so now if you want to get a colonoscopy, you've got to call a 1-800 number. And a lot of the gastroenterologists who had been private practitioners now are employees. And again, this is anecdotal. It's in something that I've experienced and others I know. It's been less medically informed than before. Um, Also, I've heard lots of stories about people who've been diagnosed with cancer, and it's taking them a long, long time after diagnosis an appointment at a cancer center. I think obviously there may be manpower issues, but I think that in some cases, if an oncologist is not available, get a nurse practitioner or a physician assistant to triage and say this is something that can wait or it should be seen more before. Again, this gets into the access and the affordability, but economics are playing a large have a large place, unfortunately, in medical care in the U.S. and around the world.
Of course, we can discuss a lot about the lack of congressional check in the current American government, and the proclivity of the American public to be held sway by pseudoscientific beliefs. But I'd like to move on to a challenge that I think, Eric, you've alluded to, the cost of cancer treatment. I think, of course, much progress has been made to make cancer not a death sentence. But even though cancer does not take away your life, it can certainly take away your savings. Secondly, the processes and treatments such as chemotherapy can be quite agonizing to go through. Thankfully, I haven't gone through that, but I've read plenty of accounts to, I guess, get an idea. So how can the American health system, I guess private and public alike, turn down the cost of cancer treatment, both the financial costs as well as the health costs?
Well, let me comment first on the perception that cancer treatment is intolerable and associated with terrible side effects. There's no doubt that there are uh, uh, bad side effects, but there's also no doubt that the same process that has led to the development of improved therapies over the last 30 years has also led to the improvement of better adjunct treatments, you might say, the medicines to prevent the side effects. So medicines ranging from stimulants to the bone marrow that will prevent low blood counts that often occur with chemotherapy and then lead to infection. That's much, much less an issue today than it was 30 years ago. Nausea and vomiting is the poster child for how bad quote unquote cancer therapy can be. And the scientific community has expended considerable resources in developing many, many new approaches, understanding what causes nausea and vomiting and developing agents that will block that side effect to the point now where almost all the treatments that I used as a young oncologist in patients in the hospital, because you had to have them in the hospital to control the nausea and vomiting and to make sure they remained hydrated. Those are easily done now as an outpatient with patients not even having nausea, much less vomiting. So I think the the cancer treatment community is not unaware of the need to develop better approaches to controlling side effects of cancer therapy. And as you noted, one of the side effects of cancer therapy is, in some cases, the very considerable cost of those therapies. I think everybody in this field is concerned about cost and looking to processes to try to contain cost by developing newer and less expensive approaches to therapy. I think it's also important in some cases to be sure that you balance the cost against the economic gain that is achieved. While it may be very expensive to cure a cancer with a very expensive treatment, if you cure that cancer and provide another 70 years of normal life to that individual, there's an economic benefit that's not necessarily immediately obvious. But if you stop and think about it for a while, it's part of the infrastructure or part of the argument that needs to be put in place. So no doubt these are important issues, but they're very important issues that that the cancer treatment and care community, cancer research community are not oblivious to at all.
Well, quality of life has become a central component of cancer care. I think it was in the 1990s, the Oncology Nursing Society had an initiative to deal with anti-nausea, with nutritional supplements and other quality of life aspects. But the interesting thing is when we spoke with people who were among the originators of, or the founders of oncology and clinical trials, specifically somebody like James Holland. Um, in their days in the 1950s when they were working on what today would be considered primitive but also groundbreaking therapies, um, they were they wouldn't worry that much about the side effects. Is just keeping somebody alive in those days, especially with the, I guess, the leukemias, right? Skip, in the with the early work being done on the blood cancers. Um,
Yeah, and I think that's true, Eric. Although it's also important to recognize that folks like our good friend Jim Holland and others were focused on how to treat the cancer and perhaps less focused on a day-to-day
no,
basis
absolutely.
on the side effects. They were also working with colleagues who were just as concerned about minimizing the side effects. So,
Right.
in parallel with the development of more and more aggressive treatments for lymphoma and leukemia at the NIH, for example, the National Cancer Institute, there were also scientists working on white blood cell transfusions and isolated environments, sterilizing all the components of a medical care system that a patient is exposed to, so that at the time, as there were approaches to develop better treatments, there have always been the folks interested. The system for supporting cancer research has always provided for making sure that we are attendant to the side effects and minimizing the impact of cancer treatments on patients' normal life.
No, you're absolutely correct. Maybe what I didn't do is put it into context, and that's one of the things we did in the book. Back in those days, the interest was in just keeping somebody alive, getting them past a lot, letting them live for the next day, because things were just starting out. Later on, I mean, it was not that they were uninterested in the supplemental and supportive care, but at that point it was the very early days of cancer research. And that's why it's important to always take what was happening at the time it was happening into context. There were procedures done in the early days that did not, would not necessarily get institutional review board approval today. It was sort of, you had to be a cowboy in those days. And that was necessary back then because it was just the very early time. As things progressed, then more guardrails came into effect, and the regard for the quality of life became more important as well, so that people are living. I mean, many people today have cancer, and it's not obvious or evident to people who see them because their nutrition is up and they're not nauseous and they're faring pretty well. Um, but we had evolved to this point to get to that point where the entire person's well-being is taken into consideration.
Now, I'd like to end on this note. Eric, you alluded to the unfair vilification of Dr. Fauci during the COVID pandemic. I'd like to mention also that another unfairly vilified public health expert was Dr. Francis Collins, who led the NIH at that time. And of course, Dr. Collins is best known for leading the Human Genome Project.
Mhm.
So I wonder, to what extent did that project help the process of cancer research?
The Genome Project?
Yes, sir.
Of the the Human Genome Project. That is the research that spanned many, many years to fully describe the alphabet, if you will, of the chromosomes in the human in the human animal. Was absolutely foundational in providing the basic understanding of the alphabet of the genes that the chemical structures that control the growth of cells, and hence when damaged can lead to abnormal growth. There's no question that the Human Genome Project has been foundational not only for understanding cancer and improving cancer treatment, but I would say every aspect of human health has been impacted by the understanding of the genetic underpinnings of the diseases. And every day there is a new publication describing a new change in the control patterns for DNA replication and the various chemical processes that are critical in that regard that influence hitherto unfathomable cause of a disease. So I think it's without question that understanding the genome has been one of the major advances in human scientific discovery.
And again, on a purely personal note, I will say that the vilification of either Fauci or Collins totally mystifies me because I have always considered them and most of my friends and colleagues to be among the giants of science and medicine. So I think it was more political aspects to that than to scientific ones.
And I think
Personally.
there have been many people who wish that when there are unknowns in a certain area, that somebody can tell exactly what the right answer is. And as the COVID experience teaches us, we learned every month about what was working and what was not working in dealing with that massive epidemic. So I think the science needs to continue to lead us, and it's not always linear, but always must be based on the scientific method.
Yes, and of course, just a side note, I believe during the AIDS pandemic, Dr. Fauci was in charge of the prevention and cure process too, and in that sense, he was vilified. I believe the famous playwright and AIDS activist Larry Kramer like hated him at that time.
I
Again,
think I'm not an expert in this area for sure, but it's my understanding that Dr. Fauci would agree that he learned a lot in dealing with the power of patient advocacy during that terrible time when we're trying to understand AIDS and trying to address the unmet needs of those individuals suffering from AIDS, their needs further complicated by the fact that many people felt that their needs weren't worth addressing because of their lifestyles. I mean, it was a terrible time, and I think Dr. Fauci was again a hero in that endeavor, but it wasn't always straightforward and clear as to what the right thing to do was. And I think he would agree that much was learned in that epidemic, particularly.
And also at that time, as with COVID, he was trying to follow the scientific process as close as he could. In both cases, these were unknown entities. Um, but And what often happens is the public and advocates and activists many times will react more emotionally than scientifically to, want to deal with single individuals rather than understand how it affects large populations. So I mean, it's understandable that many people may have wanted to short circuit the scientific process, but that didn't help anybody in the long term.
I think that's a good note to end on. Thank you very much, Skip and Eric, for joining the program.
Thank you for the opportunity.
Thank you.
Nice to see
Thank
you.
you.